I'm with HIPEC-Treatmentcom. I'll act as a moderator tonight with Dr. Fabian Johnston, a surgical oncologist at the Johns Hopkins Hospital, and Dr. Jonathan Greer, also a surgical oncologist at the Johns Hopkins Hospital in Baltimore. To start things off, Dr. Johnston, could you give us a little bit of your background?
Yeah, sure. Thanks for having us again. Currently, I am the chief of surgical oncology here at Johns Hopkins, and I trained here, did my fellowship here after finishing residency at Washington University in St. Louis. And then subsequently, after leaving Hopkins, I went to start practice in Milwaukee and then came back to Hopkins about 5 years ago and have been here ever since, working to grow and revolutionize the peritoneal surface malignancy program here.
Dr. Greer?
Thanks, Glenn. Thanks for having us tonight. We're happy to speak to everybody and answer any questions they may have. I trained in Boston at Mass General Hospital, and I did a brief three-year stint in the lab at New York and Sloan Kettering, and then I finished my training in Boston and went to Pittsburgh for 2 years, where I trained with David Bartlett and the crew there to learn HIPEC and peritoneal surgery, and then I joined Dr. Johnston in his group down here to continue to grow the program.
Has the program, the HIPEC program, been in existence at Johns Hopkins?
So the program started around 2010. And so Dr. Nita Ahuja and Barish et al., who have now gone on. So Dr. Ahuja is currently the chair of surgery at Yale, and Dr. et al. Is the chair of surgery at the University of Oklahoma, started the program. And it started as a smaller program, and that was purposeful. One of the purposes was that Dr. Ahuja was very focused on the science and making sure that we're not just doing operations, but we're trying to lead the field in the science. And we try to do that as well. And since then, now fast forwarding 10 years of the program being in existence, we feel that we are certainly able to, we've grown the clinical enterprise, but along with the clinical enterprise, we are starting to increase the opportunities for research across the continuum.
Okay. What type of cancers do you treat with HIPEC?
Dr. Greer?
Yeah, I can answer that. So our case mix here is primarily colorectal cancer and appendix, I think, is the main two, but we certainly have done a fair number of gastric cancer HIPECs here. Actually, Dr. Johnston was relatively early on that curve in the country, and I've continued to do so as well. We do also mesothelioma, and there are a handful of other sort of less common indications, but certainly colorectal and appendix are the main two.
Okay. What are the advantages of a patient going to the Johns Hopkins Hospital to be treated, Dr. Greer?
Oh, yeah, thank you. So I think what I often tell patients, it's about the fit, whether when they meet Dr. Johnston or I, whether they feel comfortable with our team. We have very experienced nurse practitioner and clinical nurses that work with us, as well as on the inpatient side. But in particular, the real strength is with our growing volume and our experience now, we exist in a milieu of one of the best hospitals in America. And so from every service down the line, anesthesia, cardiology, ICU, gastroenterology, we really do work with the best of the best. And so we believe that, in cases where things are straightforward and everything goes well, obviously the patients benefit immensely. But in particular, in cases where there are complications or, it's an extensive operation and sometimes a decent hospital stay, we benefit immensely from having specialists in virtually every field at the top of the heap, and it allows us to continue to have excellent clinical outcomes.
And I want to add on to that. I think what Dr. Greer is saying is so spot on, and we often think that you're signing up for the surgeon, right? And you are, right? But, you know, so many things can happen, and many patients who undergo this operation and read a lot about it know that there are so many things happening. And as healthy as you may be, I'll tell you, we have encountered many things that no one would ever have expected. And I'll tell you the number of times that I've been so happy to be here and have these colleagues in other specialties has been innumerable. And to also have a group of nurses and nurse practitioners and dietitians and physical therapists that actively think about these folks who are watching and who watch this, I think it's something that is very special. And so that's why you come to a place like Johns Hopkins. I think Dr. Greer and I certainly do a great job, and we're proud of what we do, but it's the other things, the other intangibles that can really loom large in your postoperative and perioperative care that make Johns Hopkins special.
And what are your patient outcomes?
So our patient outcomes in terms of quality are very good. And so on average, patients get out of hospital around between 7 and 10 days postoperatively. Our wound infection rates are below 2%. Our need for going back to the operation room, so reoperations being a post-op complication, is less than 1% for the patients that we do. Certainly, the bigger the cytoreduction, patients may need some blood, and that's a complication, technically, once you leave the operating room. But we, working with our anesthesiologists and our critical care group, it's the low number of patients that need post-operative blood transfusions. And certainly, in terms of long-term outcomes, we are on par with the quoted literature in terms of how long folks live. And that's really driven by our ability to cytoreduce people, right? And so we were able to completely cytoreduce. You don't generally get to the operating room with us unless we really feel that we can cytoreduce you, and we get you there. And then also, obviously, the perioperative, meaning around the operation management post-operatively. And so folks do really well here.
Dr. Greer, can you explain the operation? What is cytoreductive surgery? Dr. Johnston has mentioned that. Just for the folks that are tuning in that do not know what cytoreductive surgery is.
Sure. So it's sort of a blanket term. You know, we use it to describe a combination of operative procedures within one larger thing. So whereas in colorectal surgery, you might have a colectomy for your colon cancer, or you might have your spleen out for one reason or another, cytoreduction often involves removing multiple organs at one time. And we pretty much strive to remove all visible evidence of disease, and whether that's mucinous disease without tumor cells in it or actual tumor implants, we basically systematically explore the entire abdominal cavity, attempting to remove all gross evidence of disease. Many of the things that we remove are the lining, so the peritoneum, which is like saran wrap, but it's, instead of being sticky, it's smooth. So we can remove that layer from many parts of the abdomen without consequence. We can remove it from the diaphragm or from the pelvis or from the mesentery, the small bowel, for example. But sometimes we do have to remove organs themselves, colon, small bowel, stomach, gallbladder, uterus, etc., to achieve a complete cytoreduction. And basically, the term cytoreductive surgery just encompasses all of those things. And it's done, over the course of 8 to 12 hours, and then we follow it with HIPEC in most circumstances.
Can you tell us, Dr. Johnston, can you tell us about the research that's currently going on at Johns Hopkins in the way of peritoneal surface malignancies?
Yeah, so there are a few things that are ongoing in the pipeline. So we'll first begin with the clinical trials. And so we work very closely hand in hand with our medical oncologists. We have regular tumor boards every Tuesday at 5 p.m. where we discuss cases, and certainly peritoneal malignancies are part of that. And with that, we encourage folks, if necessary, to be on clinical trials. And so some of the clinical trials are related to combination of immunotherapies and combinations with chemotherapies in order to bring folks to be able to undergo an operation if they have high volume disease. And then on top of that, Dr. Greer and I are involved in creating some other trials. So one trial that is soon to be open is what's called bidirectional therapy. And so what that means is we will be giving patients both chemotherapy systemically through their veins and intraperitoneal chemotherapy. And with the goal of, and this is for gastric cancer, and with the goal of being able to reduce the level of disease they're having in their peritoneum to allow them to be able to undergo a cytoreduction for gastric cancer. Many people with gastric cancer present late and have peritoneal disease, and often too much to be able to undergo a cytoreduction. And so we believe this is kind of a platform where we'll be able to open this up to more patients and provide a venue to be able to do more cytoreductions in the future and to test different chemotherapeutic agents. Dr. Greer is going to be embarking on some other studies where we're going to be collecting blood and tissue samples, and he can explain more to look at things called ctDNA. And really what we're trying to do is understand who would best benefit from a cytoreductive surgery in HIPEC, because it's a big operation, right? And we want to make sure that we're providing the best care for folks. And we're also working with other top scientists here at Johns Hopkins to develop other studies around this.
Okay. Dr. Greer, who are the candidates at this point in time for cytoreductive surgery and HIPEC?
So it varies a lot by disease. The one thing that is probably consistent for almost every tumor that we offer this for is that most patients are in pretty good physical shape and are able to undergo a massive operation. So for example, if someone had a heart attack this week or a stroke, it's probably not the right time to perform a major operation. Maybe not down the road, but certainly immediately. Within certain tumor types, the rules are pretty well defined. For example, in the low-grade appendiceal mucinous neoplasm, or lamin, which is probably one of the more common indications that upon which we operate, there are pretty much very few people who are not candidates for surgery, and generally those are people who have had multiple prior cytoreductions before or have developed what we describe as end-stage disease. But the vast majority of patients that we see, we are able to bring to surgery and successfully cytoreduce. For colon cancer and appendix adenocarcinoma, so formal cancers, we do take a lot of stock in tumor biology, so understanding whether or not someone's tumor is responding to therapy. Because it's not just the cytoreduction that matters, but it's also the month off chemo before surgery and the month or two off chemo after surgery. So we're bracketed by about 2 to 3 months on either side of surgery. And if your tumor is not responding to chemo and then we hold it for surgery, we're going to find a lot more disease than we had hoped for on exploration. So for the more aggressive tumors, we rely heavily on biology. Mesothelioma, there are some tricks therein, and it depends a lot on the specific type of mesothelioma. And for gastric cancer, these are really patients with minimal disease, either cytology, meaning washings positive, or what we call a low PCI, meaning peritoneal carcinomatosis index. For gastric cancer, you have to have pretty limited disease outside the stomach. But that is a determination that I think should be made by us in concert with medical oncology and other experts here. And so I would encourage people to seek a consultation, and we'll take a look at the films and go from there.
Dr. Johnston, if a patient is a candidate, is there anything specific that they need to do prior to surgery, like exercising, lack of exercising, or what have you?
So that's a great question. There's a couple things that play into that. And so first of all, some people come in and they've lost a fair amount of weight. And whether that be, just from bloating and just not eating much, or, many people with the lamins will have that with high volume disease, or you've lost weight with those things, including just having a more aggressive cancer. And so a couple things come to play. So one is we encourage people to add protein adjuncts. And so, if you've not had Ensure or Boost or other protein supplements, we encourage people to start looking into those and taking them. Often, some people have decreased in the amount of eating that they've done because they're used to eating a certain way for 30, 40, 50, 60, 70 years. And so, having multiple small meals and discussing how to change your dietary habits to increase weight gain is important. And certainly, it's a big operation, right? And it's not a sprint, it's a marathon, and we haven't trained for those marathons, right? And so, getting out, walking, being active prior to just getting the heart rate up a little bit will pay dividends in the long run. There's an idea called prehabilitation in the surgical world, where we get you kind of, between nutrition and exercise, get you in better shape for an operation, and people do better overall after that. And we also look at nutritional labs. So when you come and see us, we get nutritional labs to say how malnutrition, because many people are malnutrition prior to surgery. So we try and optimize those things before and allow them to be in a better shape prior to surgery.
Dr. Greer, if a patient's looking for a program, what should they be looking for?
Well, I think that in general, it's about fit. So if you meet me or you meet Dr. Johnston, do you feel comfortable with us taking care of you and your family? As he mentioned, it's a marathon, not a sprint. And for many of these patients, this is a 9 to 12 month journey between diagnosis and chemotherapy and surgery and more chemotherapy. And so we end up playing a pivotal role, in addition to the medical oncologists, in sort of quarterbacking these maneuvers and coordinating closely. So it has to be someone that you trust. And we often meet, especially in the pandemic, with video visits. People have been meeting, multiple programs, which is certainly, a very reasonable thing to do because it's a big investment of your time and your health and your future. And so I think it's important for FIT to be there, because obviously if everything works out and you're cured, great, and you'll be delighted almost no matter where you go. But obviously many of these diseases can be difficult to treat and can be long processes. And so it's critical that you trust your team and you feel comfortable. I think experience is another factor that's very important. And that's one of the parts about this program that I know Dr. Johnston and I are both very proud, is how much we've grown over the last few years. And we have the capacity and continue to have the capacity to take care of these complex patients. He and I have wonderful residents and fellows and other folks that help us in the operating room and other services, as well as each other. And that's allowed us to push the limits. And so experience matters, and experience with complex cases matters. And then lastly is what we mentioned at the beginning of this program, which is about the milieu in which a program resides. And I think that there are lots of programs that have experienced surgeons with whom you are comfortable, absolutely, in this area as well as across the country. But it is hard to find a place that is a full service institution for all of your needs, whether it's medical oncology expertise, cardiology, anesthesia, et cetera. And so again, God forbid there's an issue, there's probably no place I'd rather be as a patient than here. And so I think when you're looking at programs, it's fit, and whether you like the people, experience, and of course the milieu or context in which the program resides.
Okay. And also being the Johns Hopkins Hospital, I assume that you can care for anybody in the United States or even around the world for that fact.
Yep, and we also have a pretty active international program as well that helps as a liaison. Certainly there are cultural aspects that which we're very sensitive, and the international folks really help us navigate that as well. And we, in the last year, have taken care of patients from Washington State and all across the country, really. It's a little tricky in the pandemic in terms of getting people here, not Baltimore specific, but just in the country as a whole with travel. But we absolutely have seen people from all over the country and have operated on people from all over who are seeking the best care, and we're happy to provide that.
Okay. This question goes to both of you. As you well know, we're in the middle of a pandemic. How has the pandemic affected your program?
So interestingly, very little. And I think it's twofold. One is we're able to continue doing the operations because these are we have the tiering system that's here, and these are generally tier 1 operations. And so we've been able to continue doing the operations. I think the things that we've learned and differences, we're doing more telemedicine visits, which in some respects are really good and allow us to meet people. The burdens that they're going through, many are getting chemotherapy or will be getting chemotherapy, allows them to stay at home and be in their environments and then meet us, close to the operation. So that's been very good. I think the hardest thing on most people that's been the biggest detriment is that many hospitals, and ours included, for a period of time, we're not allowing family members to be in the hospital with folks. So that is a hard thing, but what we have learned through that and adaptation is that we've been better than ever in communication. And so, I mean, just today, I was in the intensive care unit, and one of the intensive care unit docs said, I call the family directly today, let them know what's going on. Previously, that wasn't something, to be honest with you, that was happening, right? You may get a call from a nurse to update you, but now the ICU docs are being really thoughtful, and they understand what it is to have a loved one in a hospital for a long period of time, and the angst that goes on when mom and dad or grandma and grandpa are in the hospital, and you can't have that touch. And so we certainly feel like I tell people we're a family program, right? No one suffers cancer by themselves. It's a family disease. And so we want to feel like that we're part of your family and you are part of ours, and we wrap you up. And that's an institutional imperative. And I think some people would kind of be shocked that that's something that I'm saying, like Johns Hopkins, this, ivory tower, that you would have this kind of familial atmosphere, but it's true, right? And, I tell everyone I'm not that smart of a guy, but I want to make sure people feel really comfortable where they are. And that's something that I'm supremely proud of, that we as an institution and we as a program are able to provide.
Okay. Dr. Greer, do you have any comments?
Well, I just, to piggyback off what Dr. Johnston said about Hopkins in particular, we obviously have a very diverse patient population. I mean, we take care of people from right here in Baltimore to all over the world. And I think that has created an environment that is very sensitive to people's needs, actually. And I think that allows people to feel comfortable. And I've heard that from a lot of patients. Said, I really just felt comfortable with the team and inpatient side, outpatient side. In terms of COVID, though, in the initial phase of things, obviously when elective procedures and screening studies and different things were slowing down, we did see, some decline for almost a month or two, April and May, of people just getting new diagnoses. It wasn't that we weren't operating on people that needed an operation. It was simply just the referrals were not coming through. But I will tell you that the summer was the busiest I think we've ever had. And in the fall and now in the winter, we are absolutely slammed with cases and new referrals. I think there's been a delay in diagnosis for a lot of people during COVID times and getting that CAT scan or getting that colonoscopy. And so to that end, I'd encourage everyone to, stay on it and continue to get routine care. If you have rectal bleeding or what have you, see a doctor and get evaluated. But in terms of COVID now, we've been able to keep people safe. We've been able to keep them in a separate part of the hospital. We're not, treating COVID patients and then doing a HIPEC next door. We have two major wings here, and the cancer part of our hospital is mostly separate. And so we've had actually great success with keeping our patients safe and getting them through the process. And there are some hiccups along the way in terms of testing and making sure that you get your test done on time before surgery, et cetera. But once we get people to the operating room and get them through their recovery, we've really had no issues. And so I anticipate fiscal year 2021 to be our busiest in the history of our program, despite the pandemic.
We have a question coming in from our streaming audience. The patient had HIPEC in 2014 for pseudomyxoma. Would that patient be a candidate today for HIPEC? Again, another.
It certainly depends, but for folks with pseudomyxoma from low-grade appendix disease, recurrence is something that certainly can be expected, and so we certainly do repeat cytoreductions. And so I've had multiple people where they've undergone 3 cytoreductions or 4 cytoreductions. It's not to say that's a common thing, but it just gives you a sense that we select out those patients and work with them and understand and follow them closely. One of the things that is really a drawback why we say we're family and we're around a long time is, the longest I've seen someone recur is 14 years later, right? And so we keep an eye on folks forevermore. I tell everybody we're going to date for a long time, all right? So that we don't want to get to that point where it's you can't have that cytoreduction. So it depends on how much disease is there and do we think we can cytoreduce that person. But that 2014 is a reasonable time, and if there is recurrence, to be able to go again if need be.
Okay, gentlemen. Well, I want to thank you very much for your time this evening, and to my audience out there, if you need to get in touch with Dr. Greer or Dr. Johnston, just visit HipecTreatmentcom. Go to Dr. Johnston or Dr. Greer's profile, and you'll be able to arrange a conversation with one of these surgeons if you desire. Again, I want to thank you very much for your time and have a great evening. Merry Christmas to everybody.
Thank you.
Thank you, Glenn. All right. Thanks, everybody.